All right, welcome from MED-EL US. And again, thank you for taking the time to be with us today. We have a very exciting session today that we are looking forward to getting into. Just to run through a few housekeeping items before we get started. You've likely seen these participant tips with Zoom before, but please name yourself. It's nice to know who's with us today. So you can do that by looking at the participant panel and then clicking on the option that either says more or shows a few dots on your screen. And then you can put your name as well as the organization where you're joining us from on there as well. Please also do keep yourself muted so that we don't get a lot of background noise while our presenters are speaking. Muting your phone is always a good idea as well. And we do recommend, if you can, that you close all other programs that you have going on so that the internet connection will be more stable. We will have time at the end for questions and comments. So please, if you have any thoughts during the presentation that you'd like to share, you can save those for the end and we will open it up for comments and questions then. A few additional items here. You'll see at the bottom of your screen that you have the option for closed captioning. So you are welcome to add that. You can click on that and that will be available in English if you would choose to do that. So we're fortunate today to have two speakers joining us to discuss EAS Fitting with Long Electrodes. We have Dr. Brittany Wilson and Dr. Sara Funatake joining us from Oregon Health and Sciences University. So the topic of EAS fitting with long electrodes is really very relevant as we continue to see excellent results in terms of residual hearing across MED-EL's electrode portfolio. But how we manage these patients, especially from an audiologic standpoint, in order to maximize their outcomes, really continues to evolve. And we're learning more about the cochlea, we're learning more about electrode location and long-term hearing preservation, as well as starting to think more about outcomes like sound quality. And all of that, I think, is particularly relevant in terms of how we're fitting EAS in these patients who have been implanted with long electrodes. So before we jump into their presentations, we have a polling question. So you can do this with the Mentimeter system that we have up on the screen here. And we'd like to know, from which area of hearing healthcare are you joining us? Do you represent audiology? Are you a surgeon, a speech pathologist, another area of hearing healthcare? So if you can let us know which area you represent, you can do that either by going to www.menti.com and entering the code here, or you can use your phone to scan the QR code on the screen here. Either of those options will take you to the Mentimeter poll. And then once we have the results of that in, we will display those on the screen. And we'll have a couple other polling questions throughout using the same system. So this is a nice practice to make sure that we all can log into that. So let's see. All right, getting some answers here. We've got audiologists, software engineer, research joining us as well, CI specialist. So that's great. Lots of people who will be familiar with this topic for sure. Perfect. All right, looks like we've got those answers in. All right. Great. So we hope that you will find today's talk provides some insight into management, particularly from an audiologic standpoint of patients who have residual hearing, again, who have been implanted with longer electrodes. Dr. Brittany Wilson will first present on sort of the background of this topic, just to give us an idea, again, of why this is so important and why we're here talking about this today. Dr. Wilson did participate in collection of this data while at Oregon Health and Science University, where she practiced audiology for 7 years. And Dr. Wilson recently joined the MED-EL US clinical research team here as well, and we're very happy to have her working with us now as well. So I will go ahead and turn it over to Dr. Wilson.
Thank you, Allison. All right, yeah, good morning and good afternoon to everybody. I'm Brittany Wilson, and it's good to be here. Thanks for joining us. As Allison mentioned, I was a clinical audiologist at Oregon Health Science University, or OHSU, in Portland, Oregon for a few years before joining the MED-EL research team. Today I'm here with my colleague, Sara, and we're going to talk to you a little bit about our experience fitting EAS with long electrodes. These are our disclosures. And for our agenda today, as we mentioned, I'm going to share a little bit of the background, some of the literature on EAS and the functional benefits that we know it can provide. We'll look at some of the surgical and clinical considerations for fitting EAS and for hearing preservation with long arrays. And then we'll look at OHSU's preliminary hearing preservation data with their long arrays and their EAS protocol. And we'll wrap up with some case studies on EAS fitting with these long arrays. All right, so as a review, EAS or electroacoustic stimulation combines electrical stimulation of the high frequency sounds via the cochlear implant array with acoustic amplification of low frequency sounds in order to cover the entire range of frequencies in cases of preserved low frequency hearing. So this is a schematic of the MED-EL EAS system with the Sonnet processor. EAS is indicated really for patients with some degree of preserved low frequency acoustic hearing. So this may be patients who are on the higher end of the audiogram and the normal thresholds in the low frequencies. But as we're going to look at today, some of these patients are also more in the moderately severe range. So there's really a spectrum of patients who can benefit from EAS. There are some known benefits. It's been well documented in the literature for over the last 15 or so years. And some of these known benefits and the big ones really include improved speech perception, not only in quiet, but also in complex background noise, improved pitch perception ability, and subsequently enhanced music perception and appreciation. The addition of acoustic low frequencies to electric hearing leads to the enhancement of these different features, the temporal fine structure and speech intonation cues, and spectral matching of spiral ganglion frequencies, as EAS is able to provide both correct place and time coding in those low frequencies. So there's a whole body of literature on the topic, but this study from Dillon et al. From 2015 comparing speech perception ability across different listening conditions in EAS users really illustrates the advantage of this additional low frequency information for improved speech comprehensions. In their study, 11 subjects implanted with the MED-EL Flex EAS array completed speech perception testing in 3 conditions. So the full frequency map on the far left, that's going to be the full electric bandwidth, 70 to 8,500 hertz. They also did it in a truncated map, which is using an audiogram-based low frequency cutoff. For instance, it might be something like 250 to 8,500 hertz. And then the EAS condition, it shares the same electric bandwidth as the truncated, but it has the addition, obviously, of the acoustic gain. So on this test, this is presenting the results for CNC words, which is open set, word identification, and quiet. And they found that performance was significantly higher in the EAS condition overall. This performance pattern carries over also into the noise condition. Here we're looking at the CUNY sentences in noise and a rather challenging SNR of 0 dB SNR. And we're seeing the same pattern where the truncate is performing higher than the full frequency, but EAS is performing significantly better overall in these conditions. And I really think this study illustrates the functional communication benefits of EAS as a result of those enhanced speech intonation and temporal fine structure cues. EAS use, as mentioned, has also been shown to benefit CI users' music perception ability. In this study from Brockmeyer et al. From 2010, they evaluated various aspects of EAS users' music and pitch discrimination ability using the musical sounds in cochlear implants or music test. And the music test is comprised of objective subtests, which assess aspects of pitch, rhythm, melody, harmony, and timbre perception. In the study, they compared music perception abilities of 13 EAS users to 2 control groups. The NH group is going to be a group of normal hearing listeners. And then the CI group was a group of unilaterally implanted CI users who did not utilize an acoustic component. And then the EAS users were also compared back to themselves with the acoustic component disabled. And this is going to be the EAS CI only condition on the far right. So on tasks of rhythm, chord, and melody discrimination, the EAS users scored on par, if not better, than their normal hearing controls. And I don't think this is too surprising of a finding, because we know that this is actually a strength of some of the envelope coding that's inherent to the CI system. But when we compare the CI conditions, the EAS condition is scoring better in nearly all of these domains on pitch and instrument discrimination. And there was also a significant relationship between instrument discrimination ability and postoperative hearing thresholds at 250 and 500 hertz. So better thresholds or lower thresholds resulted in more accurate discrimination ability. And it's important to note for this study, they actually utilized the MED-EL standard electrode, which is the longer 31.5 millimeter array. So here we're actually seeing effects of EAS with longer electrodes. But historically, EAS has actually been utilized primarily in conjunction with shorter electrodes, with the benefit being reduced risk of structural damage and loss of good low frequency hearing. The main downfall of a shorter array is, of course, loss of residual hearing and ultimately missing cochlear coverage. So in this schematic below, we can see an example of the estimated insertion depth for a 20 millimeter flex 20 array, which reaches roughly 360 degrees into the cochlea, which corresponds to about 1,000 hertz. If a patient implanted with this insertion depth were to experience a significant progressive hearing loss after activation, the frequency bandwidth would be dramatically compromised. So in these instances, we really have a couple of options. We can either leave a place-based map, which just means leaving our electric boundary right where our audio cuts off. We stand to lose a lot of substantial low frequency information in that case. Or we can reduce our low frequency boundary to cover that range, but then we introduce a really large spectral mismatch. So why use EAS with longer arrays? Really, it makes sense for a few reasons, but I think the most important of which is ensuring full cochlear coverage if there is a progressive hearing loss. In the most extreme cases, this may mitigate the need for a revision surgery, but having a full length array provides a fuller spectral bandwidth for speech and improved spectral matching. The same benefits that we were describing earlier for EAS are definitely applicable here for a longer array. That also includes improved naturalness of sound quality, which we have a few case studies on later on. And this can be important not only for new, but also experienced users who are still struggling with adapting to electric stimulation, as well as improved speech clarity and complex noise. And EAS with longer arrays is now an evidence-based approach. So there's a really big growing body of literature which supports the preservation of residual hearing with longer arrays and the effectiveness of additional acoustic information in this population. Go ahead and hit next slide. Thank you, ma'am. So this recent systematic literature review from Van de Heining et al. From 2022 looked at publications on hearing preservation with the longer MED-EL electrodes from 2009 to 2020. And they included studies that reported hearing preservation rates by applying the hearing group's hearing preservation classification system. And they analyzed hearing preservation rates for patients implanted with the MED-EL Flex 24, 28, and Flex Soft arrays. So here are the studies that met criteria who evaluated patients with the Flex 28 and the Flex Soft. So these are the longer array group. And results are broken down by the study, the surgical approach, round window or cochleostomy, and a short and long-term data point at 4 and 12 months respectively. And the overall results revealed comparable and high rates of hearing preservation for both groups, averaging 86.7% for the Flex 28 group and 86.9% for the Flex Soft in the long term at the 12-month interval. And here we can see the global comparison of hearing preservation rates across the 24, 28, and Flex Soft arrays. And they found no statistical difference in short or long-term hearing preservation across any of the electrode variants. And the authors acknowledged that both these medium length and longer length electrodes showed high hearing preservation rates. And considering hearing deterioration over time, that implanting a longer array at primary surgery should be considered if possible to prevent the need for reimplantation down the road. So next, I briefly just want to discuss some of the surgical and clinical considerations, which may differ slightly for hearing preservation with a longer array. First off is our hearing preservation electrodes. And really the objective here, as always, is to reduce risk of scalar translocation and any further potential damage to the spiral ganglion. The way we achieve this is typically with a flexible, thinner array that's oftentimes a lateral wall design. And as we've discussed now, electrode length is not of primary consideration if we're selecting a very flexible atraumatic array style. Surgical techniques, which we're often hearing described as soft surgical techniques, aim to reduce risk of further hair cell and spiral ganglion damage and increase control and visualization of the electrode insertion. So the way we accomplish this is typically with a round window approach, drilling a facial recess that's sufficient for visualization of the round window overhang, by avoiding trauma to the cochlea, like drilling directly over the promontory, reducing debris like blood and bone dust in the scala tympani, and very importantly, using a slow insertion speed. Steroids may also be used to reduce the inflammatory response in the cochlea and mitigate the effects of surgery on residual hearing. The most common approaches during surgery are going to be IV steroids or topical steroids at the round window, and a more novel approach would be via the implant itself. Outside the OR, you may see an oral steroid taper prescribed either pre and or postoperatively. And finally, feedback on electrode insertion. It's going to provide the surgeon with confirmation of electrode placement, the ability to identify acutely if there has been any structural damage, and to monitor residual hearing throughout surgery. A few of these mechanisms include ECOG, which has shown some growing popularity in recent years for detecting the electrode location within the scala and detecting changes in hearing during or intraoperatively. ECAPs have long been used to confirm electrode placement and can provide some feedback on nerve integrity. And imaging, which we can use to obviously verify location, but we can also use this in conjunction with a post-op audiogram for programming EAS. So audiologic considerations, largely the audiologic considerations are going to be counseling based for pre-op assessment. So obviously your audiogram should be reviewed to determine if an EAS processor could be considered postoperatively if there's any chance of maintaining better than a 65 dB threshold from 125 to 1000 hertz. The patient should be counseled appropriately on the potential for ear mold use for this BTE processor. They should be made aware of the potential changes they can experience in hearing postoperatively. It might be correlated with acute changes due to resolving fluid, but they also need to know what to expect long-term for hearing preservation and EAS use. But of course, there's no guarantee for total or even partial preservation, so conservative counseling around this point is very important. So again, in the fitting considerations postoperatively, as mentioned, we want to make sure we're including patients who have thresholds above 65 dB. This is going to be done automatically for you in Maestro software. But for your ear mold ordering, this is something to consider in terms of the timing of your impression, the style and the venting options that are going to optimize comfort and gain. Your stimulation strategy, which may include complementary fine structure in the apex, and determining whether you want to use a paired method or a standard FS4 depending on your acoustic cutoff. And finally, reviewing your protocol of when you want to test residual hearing and when you're ready to activate it. And actually, we're going to hear from Sara next on the protocol that's being used at OHSU. But first, I believe we have a polling question for the audience.
Right. And our second polling question here is, which electrode is your clinic's choice for hearing preservation? And again, you can log into the Mentimeter here, either through menti.com and enter the code, or using that QR code we just had up on the screen. We should see some results popping up here shortly. See Flex 28. That seems to be a popular response. Flex 26, that's good to know. That option is also available. Great, so we've got some Flex 26 and some Flex 28. Glad to see that there are those using longer electrodes out there. Definitely Flex 28 looks like a popular option, so this is perfect for today. Great. All right, thank you for those responses. This is something that personally is important to me, and I'm glad that we're having this discussion because, I think back, and at this point we have decades of information and literature on hearing preservation rates with various electrodes, which is fantastic. But it took us so much longer to really start talking about what that looks like from an audiologic perspective. We don't have nearly as much literature supporting exactly how we're fitting these patients. So again, really glad that we're having this conversation today and that we continue to see more information coming out about what that looks like from an audiologic perspective. So now we will turn it over to Dr. Sara Funatake, who will discuss some of the outcomes that they have been seeing at OHSU, where she's been practicing audiology for 5 years now. So again, she'll share some data on hearing preservation outcomes, and we'll talk about that clinical protocol for fitting EAS patients. And then Dr. Wilson and Dr. Funatake will also talk about some case studies that they've seen.
Thank you. Let me just pull up my slides again. There we go. So we are looking here. Can you guys see the slides? Okay, perfect. This is looking at our clinic's shared experience fitting acoustic component in the longer arrays. Brittany, even though she's now at MED-EL, she also had experience in this. So it's really nice to have her now MED-EL hat as a perspective in this discussion. So before we jump into anything really with case studies, I did want to talk about what our data that we're collecting in the clinic is looking like. We have been for quite a while now comparing the hearing preservation outcomes in our recipients with Flex 28 and FlexSoft electrodes. And like a lot of you had mentioned in the polling question, the Flex 28 is also our electrode of choice for hearing preservation. So because of that, we do have a larger population of recipients in this array. In the US, the FlexSoft was only fairly recently implemented. It received US approval in 2018. So we don't have as many recipients using this device, and we do recognize that. So because there's this difference in population size between our groups, we did have to take that into consideration with our study. So what we're looking at right now is adult cochlear implant recipients who are 18 years and older, again in Flex 28 and FlexSoft. They are a combination of traditional cochlear implant candidates and EAS candidates. And our Flex 28 recipients were matched based on their preoperative speech scores and their low frequency pure tone average to better match our FlexSoft recipients. Our low frequencies that we're looking at are from 250, 500, and 1000 hertz, just for reference. So what we're seeing, let's take a look at the Flex 28 group here. We have a sample size after matching of 22 recipients. In their low frequency pure tone average, preoperatively, they have about a 70.1 dB pure tone average. Post-operatively, we're seeing at about 92.75. If you want to round up, 93 dB. So early average shifts that we're noticing in this population is about 22.7. Again, if you want to round up, 23 dB. And this is looking out to 9 months. So this is very early preliminary data. The audiogram that you see below in the dark blue, that's the average pre-op audiogram. Below that in the red, that's the average post-op audiogram. And again, looking out to an average of 9 months. And we also have the standard error bars there, just so you can see where all of our recipients are sort of falling within that range. But when we take a look at our FlexSoft recipients, Flex 28, we had 22 recipients. FlexSoft, we only have 8. Their low frequency pure tone average was about a 78.8, 79 dB. Post-operatively was about a 99 dB. And similar time frame, FlexSoft to Flex 28, about 9 months post-operatively, we're seeing about a 20 decibel shift in the early stages of their cochlear implant usage. And like the Flex 28 below, you can see the FlexSoft's hearing preservation data. Again, the dark blue line representing the average audiogram for those recipients, and below in the red, representing the average post-operative audiogram recipients. And we do, again, recognize that this is a really small sample size. However, just within the small data we have, it's actually pretty encouraging. So we're hoping to be able to add on more FlexSoft recipients in the near future. So overall, what's our preliminary data telling us at this point? I think what we're seeing a lot in the literature is we're very on par with that. 20 to 23 dB average shifts in the early stages post-operatively for our Flex 28 and FlexSoft recipients respectively. A great thing with what we're also seeing is that in both of these groups, we do have recipients utilizing an acoustic component, and we do have some case studies that will highlight that in just a little bit. And again, we would like to add some more FlexSoft recipients to this grouping so we can have a better comparison of these pre to post-op outcomes, looking at pure tone averages, as well as speech perception scores, particularly AZ biosentences in quiet. So we kind of know what we're looking at with our population, but what are we doing with this, or how are we coming up with this information? So we do have a protocol. There's a lot of wiggle room in our protocol, but we do have a general protocol that we're using when it comes to fitting the acoustic component. This is just a nice little timeline of what we're looking at here. For an initial activation or an initial stimulation, if we suspect that a patient might be able to use an acoustic component, we're trying to take an ear mold impression at that appointment time. Especially in the time of the pandemic, ear molds are taking a lot longer to come in. So we want to make sure we have enough time to get everything in an appropriate amount of time. And then when they come in for their 1 month post-activation or post-operative appointment, that's when we're actually going into the sound booth and we're testing hearing preservation. We're going to do otoscopy, tympanometry. Let's make sure any middle ear impacts have been mitigated, and then air conduction thresholds in the cochlear implant ear before we jump into aided testing. And we do this again at the 3 to 6 month mark, at their 12-month post-op, and then at their 18 to 24 post-op. There is a range that you see here, and that's because we do have a few studies going on in our clinic, which means some patients are coming in more regularly. So there's a wider range of when we're seeing patients. But on average, our adult cochlear implant recipients are seen for 5 post-op appointments in the first year of their implant. After that first year, we're just retesting them on an annual basis until they are no longer able to use an acoustic component if it comes to that. But if a patient is calling in or sending us messages feeling like they've had changes either in residual hearing, in the sound quality of their implant, or just overall speech perception, then of course we're bringing them in sooner. We're going to do another unaided audiogram and then reprogram the acoustic component if necessary, and just overall remapping. And there's a reason why we're waiting until the 1 month marker to see patients for residual hearing testing. And this case right here is highlighting the why. This is looking at testing residual hearing at an initial activation appointment versus when we test at later intervals. So this is a 60-year-old with a unilateral Flex 28 cochlear implant. The black audiogram that you see below, that's representing the pre-operative unaided audiogram. And then when this gentleman was tested at their initial activation, we can see an average shift of about 32 decibels. So still good low frequency hearing, but a little bit of a larger drop than what we're seeing on average. However, when you jump to 1 month later, we can see the blue line, that's the 1 month post-op audiogram. This individual's actually had improvements in air conduction thresholds on an average of 10 to 20 decibels. So had we potentially activated the acoustic component at the activation, if we'd had the opportunity, we could have been overstimulating or over amplifying this individual in those low frequencies. And again, this is an individual with a Flex 28. It's a longer array. And we're now seeing out to 12 months postoperatively, unaided audiograms, they've been stable within 5 to 10 dB if you're looking at the 1 month out to the 12 month. There are certain areas, if you look at the 12 month and the mid to high frequencies, where there has been some improvement, and it almost matches up with the pre-op audio. But this is a nice case to highlight a couple of things of why we're waiting till later to test residual hearing to fit EAS, but also why we are using the Flex 28 as our hearing preservation electrode of choice. We'll jump into more case studies about this, but it does look like we have another Mentimeter polling question for you guys.
Yes, so we are curious, which interval or intervals do you typically test for residual hearing postoperatively? Do you typically do that at activation or at the 1 month visit, again at the 12-month visit? We should have the QR code and the menti.com code here. So if you can enter, I think you have the option to enter more than one response. Which interval or intervals do you test for residual hearing postoperatively? Again, I'm so glad that this is a topic of conversation now, because, you know, initially when we first started realizing that we could preserve hearing with EAS electrodes, I think a lot of people didn't know exactly when they should be testing for residual hearing. So now that that has caught on more, looks like we're seeing some tests for residual hearing at 3 months post-op, which is great. I think, you know, keeping in mind what that looks like over time is also a good idea, as you mentioned, kind of looking out, you know, testing annually, but if patients are reporting a change in their perception or their sound quality, remembering that that's something to check as well. We've got 1 week after they get activated, 4 weeks, 3, 6, 12 being a protocol there. That's great, 1 month. So a variety of responses, but honestly, I think that's fine. It's just great to see that people are keeping in mind that they should be testing for residual hearing. And one question for you, Sara, and maybe Brittany as well, you know, something that's been a topic of conversation over time has been the benefit of using an ear mold versus whether there's any benefit to using, you know, a receiver in the ear situation. And I think, you know, using a receiver makes it easy to activate right at that initial visit. But with what you're seeing, activating the EAS a month later, I guess sort of 2 parts, do you think that the benefits of using the ear mold then outweigh the benefits of using the receiver? And secondarily, do you think there's any potential harm in waiting for a month before activating EAS, before activating the acoustic, or do patients seem to tolerate that fine?
I would say in my experience with receiver in the ear style acoustic components, they often break. So a lot of my patients who can utilize something like that are often, you know, flip-flopping pretty frequently between a truncated map unintentionally and the acoustic component. So they don't really get the time that I would like them to have to adapt to from full electric to acoustic and electric. So that's been something that I've seen, whereas something that's more of a BTE style, like what MED-EL has, it's sturdier. So I don't have as many concerns. And I have a little bit more wiggle room with ear mold styles too, which has been pleasant because ear molds get remade frequently. So there's been that I've personally enjoyed.
And activating the acoustic at the 1 month, patients seem to do fine with that.
Yeah, they'll say they can hear a difference.
Mm-hmm.
But a lot of them will say, oh, but this one sound that bothered me for a really long time, I'm not noticing it anymore. So there's a learning curve still with that, but the sounds that they will just always tell you are a bother, when you can fit that, they'll say, oh, I guess I don't, oh yeah, I know you're right, I don't hear that anymore. Okay, I'll try it.
Right.
And that's enough for them to want to stick with it.
That makes sense. Thank you.
Yeah. All right. I'm going to pop back to my screen.
We did have a question come in that I will
Yes.
Questions at the end. I think we can move on with the case studies to make sure we have time to get to everything, and then I'll go back and pull the questions at the end.
Perfect. Oh, there we go. All right. So this was looking at, it was nice to see a range that everyone had, because there are times where I think we should be good at 1 month to do an unaided, but they still have a little bit of fluid back there. So we are waiting till 3 months. So it's nice to see that everyone kind of has a range of what they're doing in their clinic too, because there's no set way, which I think that's a big thing about this, right? Like there's no set way in how you should do this. Which also you'll see in our case studies, we have a protocol, but we do have wiggle room in a lot of what we do. So let's take a look at how we're putting our protocol into practice. We've got about 4 case studies that we're gonna look at here. So this first one, this is a 38-year-old male. He had rapid, progressive, high frequency sensory neural hearing loss, but we didn't know why. We didn't know what the cause was. And for him, a keyword is going to be progressive hearing loss. He did report about 4 years duration of his deafness, but a benefit for him and a benefit for us in audiology was he was a consistent hearing aid user. He did qualify for his cochlear implant under FDA's guidelines for EAS stimulation. So even though he qualified under EAS, which FDA EAS, which is a Flex 24, we did fit him with a Flex 28 because of all of our experience that we've seen with hearing preservation and the longer arrays. He is somebody where at 2 weeks post-operatively, we were able to go into a booth. We had time to do an unaided audiogram. And we were also able to fit his acoustic component at that time. He is, I think in the world now, everything's like pre, peri, and post-pandemic. He's a pre-pandemic gentleman, which meant we did an ear mold impression at activation and we got it by his 2 week, his ear mold by his 2 week appointment. So if we see in the black, the pre-op, the orange, the post-op, he still has pretty good low frequency hearing out to 250 Hertz. So he's got an acoustic cutoff of 327 Hertz in his mapping strategy. Because EAS can feel like a lot of touch and go, you're not quite sure what your ear mold's configuration is going to be. We did fit him with a skeleton style ear mold, can help out with some occlusion issues, and a select event as well to also help out with some potential occlusion issues. He is in an FS4 strategy, which is what is recommended for EAS. So he is using that strategy without issue. And as a part of our clinic, we're doing ESRT regularly. So he has MCL guided ESRT for his mapping. So this is his map that you can see below. This is the ESRT guided map, and you can see where his ESRT are, those lime green lines, just to highlight that. So even though we did ESRT, they look great, he has responses, we still have to do some fine tuning for sound quality. Because had we just left it at this with EAS and ESRT, he reported that sounds were echoey, that there was a hollowness to speech and a little bit to his own voice. So what did we do to mitigate that? We ruled off the fine structure channels. Your fine structures are electrodes 1 through 4. So there we go. That's the new map configuration right there. And what did he tell us? He said he noted an immediate improvement in the sound quality with EAS and some rolling off of the fine structures. Sounds were smoother, less choppy. And a word that we like to hear in audiology, especially for those of us in cochlear implants, is it sounded more natural. That's the whole point with a lot of this. So the fact that he could say speech was more natural was a huge bonus too. And another benefit was not only did it sound better, but we were seeing significant early speech perception gains from him being able to use the acoustic component. So these are his AZ bio sentences. in quiet. As we can see preoperatively, a pretty low score, right? 21%. That's not a very good score. But at 1 month, when he's had 2 weeks experience with his acoustic component, he immediately jumps up to 93%. And he's maintained those high 90s, 99, 97, 99, 3 out to 12 months. So he's essentially hitting the ceiling on AZ biosentences in quiet. And again, he's met criteria under EAS criteria, but he has a Flex 28. And now we can take a look here and see his unaided audiograms from pre all the way out to the 24-month milestone marker. And he's still able to use 2 years later his acoustic component. And that's lovely to see. You know, he still has really good preserved hearing with a longer electrode array. So this next case study that we're going to look at is not somebody who is using EAS, but he didn't meet under EAS criteria. He is a 75-year-old gentleman. We do know the cause of his hearing loss, significant noise exposure, primarily from military, and he was a farmer. So lots of noise from childhood through adulthood. He reported about 30 years duration of deafness. Of those 30, 25 years, he was a good, consistent hearing aid user. He qualified for his implant under Medicare criteria, so not EAS criteria, because we knew he'd had progressive hearing loss. The surgeon and I decided we should try a Flex Soft, which is the 31.5 millimeter array. And lo and behold, he also has a full insertion, which is lovely too. And below here is his, below to the right is his audiogram. He has okay low frequency hearing. It's not great. So we knew we weren't really risking too much if we did a longer array. But the best part is he still has excellent low frequency residual hearing. And we can see it out to the 6-month mark there in his stacked audiograms from pre to 6 months. But he wasn't fit with EAS right away. He was initially activated actually in an FS4P strategy. He liked it. He liked the low frequency, liked the power. So we kept him in that strategy. He was in a full electric from his activation. So 70 to 8,500 Hertz were the frequency bands. But something he was consistently saying was speech hisses, my wife's voice hisses, TV crackles, it's a cracking sound, but it's not all the time, but it's a lot of the time. So we decided, let's just do a quick unaided audiogram at your 2-week marker. Let's see what that looks like. Okay, doesn't look too bad. You've got low frequency hearing. Let's try this. Let's see if this makes it better. And he was on board. So at his 1-month milestone appointment, we got his ear mold impression in time and we fit him with his acoustic component. He also is a gentleman that we did ESRT guided mapping by, again, looking at the lime green bars below. Also, like the previous case, we did have to roll off MCL on the fine structure channels 1 through 4, just to reduce some of that echo and hollowness to it. But he immediately noted that the hissing was gone. He liked it. Speech was much clearer. It was easier to hear. He was happy. So by the time I saw him at his 6-month milestone or his 6-month post-operative appointment, after we did sound field testing, took him to the office, checked impedances. I asked, what changes would you like? And he said, no changes. Don't touch anything. I said, great. I'll see you later. And that was amazing, you know, to know that he liked his acoustic component, he liked his ESRT guided mapping, and he wanted no changes, which was lovely. That's kind of what we also want in audiology, especially with our time constraints. Something else, so of course the patient report is lovely, but also again, we want to look at their speech scores over time to see if they're really getting a benefit. Preoperatively, very similar to the previous recipient, was a 23% hearing aid, so pre-CI, AZ biosentences. At 1 month, he was 70%, lovely. We had a little scare moment at 3 months. He dropped down to 47%. Had no idea what was going on. Oh, checked impedances. He had an air bubble. In Oregon, everyone has allergies. He's a chronic nose blower, so he put air right above his receiver stimulator. But once he was able to massage that down and get the bubble to go away, I saw him again for 6 months, and he jumped right back up to 78%. So I just wanted to show that. Didn't want to leave that out. Didn't want you guys to think I was being sneaky. He had an air bubble, but otherwise he's doing great. And at 6 months, he didn't want any changes. I haven't seen him since because he lives 5 hours away, which is understandable. So yeah, that is a FlexSoft EAS user. I'm going to pass the microphone actually back to Brittany, and she's going to cover these last 2 of her cases.
Thank you, Sarah. Yeah, I think these first 2 cases kind of exemplify maybe what you would consider a typical EAS fitting with that, the first candidate. And then the second one is kind of unusual because it's a FlexSoft, and it's cool to see that we're still able to implement it. This next case study is highlighting ear differences. So this is actually a bilateral EAS user. He was a 60-year-old male with rapidly progressive bilateral sensory neural hearing loss. You see a theme here. So that's really important because that's largely why we went with the 28, as Sara alluded to earlier. This individual also had a 10-year duration of hearing loss, and he was a consistent hearing aid user prior. You can see his audiograms on the right-hand side. We've got the right ear in red, the left ear in blue. These are the audiograms at the time of surgery. So these are taken at different time points, and I'll kind of explain that in just a minute. But bottom line, you can see he has a lot of low frequency hearing to preserve. So he did meet the EAS criteria, and we did do sequential implantation with the Flex 28. So a few notes on that sequential implantation. I've got his audio on the right-hand side at the bottom. This is for the right ear. This is his second ear, not the first ear we did. But his scores are on the left-hand side. And really, this is just to show kind of the dramatic change that we saw in his performance and in his audio in a relatively short period of time, 3 years. So in our initial evaluation in 2018, you can see his right ear score was really quite strong. So he didn't meet candidacy criteria in that year at all at that point. His left ear, by comparison, you can see he was scoring 47%. This is on an AZ biosentence and quiet task, which, as you know, if you're fitting EAS, you know that for EAS users, this is a bit of an easier condition. So left ear definitely was ready to be implanted. But then we saw a rapid decline in his hearing, his audiogram, which we can see again on the right-hand side. His 2018 audio is in blue, and then the 2021 is in black. So, relatively a moderate shift there, but his speech perception score, I think, was the most marked decline, going from 87% to 33% in that same condition of aided AZ bio quiet. So again, this is what led to our sequential implantation. But we're going to look first at his left ear. This is the first ear that we did. So this is looking at his audiograms again on the right-hand side. We can see his pre-op audio compared to an activation audio and a 1-month audio. And again, this was a pre-pandemic patient. So I was testing his hearing at activation, anticipating that we might want to be fitting his acoustic component within the next 4 weeks. And we did. So it was activated with an acoustic cutoff of 500 Hertz because he did have a pretty healthy maintenance of those low frequencies. We utilized an FS4 strategy, which is recommended. And then we did get ESRT on him, which is what we use to guide our MCL configuration. So this is what his map looked like on that left ear at 1 month. Aside from ESRT kind of shaping the map, we did disable electrode 12 for sound quality, which is, in my clinical experience, something that I did fairly regularly just for if there was something like the hissing like Sara was describing. Otherwise, we're using default acoustic gain and frequency cutoffs. So we can see the center frequency for electrode 1, which is our lowest frequency, was 574 based on his acoustic cutoff. So it's a pretty standard looking map here. And on our next slide, we're going to see, what his response was to activating EAS. Immediately, improvement in sound quality. 1 month of experience, I appreciated the feedback from everybody. I definitely agree that you can do this at various points. And I think the reason 1 month made sense for him is because he was having some perceptual differences, and we'll look at this with his other ear, but the robotic electric kind of quality he was struggling with. So he really appreciated the sound quality. And furthermore, his speech perception was benefiting from it. So we're looking at his speech scores on the AZ BIOS sentence and quiet task on the first row. And the second one is our CNC word score and quiet. And we can look at our pre-op to our 1 month and 3 month, and we see pretty, dramatic improvements as early as 1 month, especially for the sentence task. So we were really pleased to see that perceptually it sounded good, and objectively his performance was improving. And so overall left ear outcomes, again, this is the first ear. He did really well. This is showing his audiograms out to 36 months. He's still able to use his EAS component 3 years later, and his acoustic cutoff is, remarkably still set at 500 hertz. So a pretty great case for EAS use. So now we'll kind of pivot and look at his right ear for comparison. So this is his pre-op and 1 month audio for that right side. And immediately you can see, not the same story. He did not maintain quite as much hearing as acutely right after surgery. So this resulted when we did activate EAS, and we did activate it at the same time point, the same interval, just to keep things as similar as possible between ears. Again, same array length, but the acoustic cutoff is 250 for this ear. We stuck with an FS4 strategy. ESRT was absent in this ear. I think that's kind of another interesting component to consider with this etiology that's unknown, but there's clearly something at play that's affecting this ear pretty rapidly. So MCL were set behaviorally, and on our next slide, we'll see what that map looks like. Again, default acoustic gain and frequency cutoffs. This is what the MCL looked like set behaviorally. On our next slide, you're going to see just a comparison, so you can kind of see like what did it look like at 1 month for both ears. Despite not having ESRT, pretty similar looking map configurations and map levels. Really the main difference is our acoustic cutoff between the two ears. So 250 on the second side, the right ear, 500 on the left side. So our response to EAS activation on this side was also positive. He did appreciate the adjustment in terms of the sound quality. We did do some speech perception testing comparing EAS on versus off, which we just had the time and wanted to see what he thought about the difference. So EAS off is going to be a full electric bandwidth, so 70 to 8,500 hertz, whereas the EAS on is going to be with the acoustic component, obviously. And what's cool is that he was doing great in both conditions, but there was a clinical significance to adding that acoustic component, which we were happy to see. So despite all of this, he did report that sound quality was still not quite as natural as his left ear. He reported it was a little more robotic, a little bit less clear than the left ear. I'm just showing his two scores. Just comparing the right and the left at that same interval, just to kind of demonstrate that he's not doing terribly on the right side, but still there persisted some sound quality differences on that side. So possible explanations for outcomes. I think it's very obvious. We can click next there just to show those audiograms. The greater loss of residual hearing, both on the pre and post-op side for that right ear. So again, we're not really sure what the mechanism was that was contributing to that rapid progression, but something was clearly affecting that right side. So he entered into the OR with less residual hearing, and then he also had a greater decline in residual hearing post-operatively. And this resulted in a wider electric bandwidth for the right ear, causing that robotic quality. So the bandwidth on the right side was going to be, closer to 293 to 8,500 versus the left ear, which was 573. So that can certainly contribute to the difference in sound quality. But then, we didn't do a CT scan to confirm where the electrode was. So it's really difficult to say if electrode location isn't at play as well. We know that differences in insertion depth can play a role in sound quality differences, and then ultimately speech perception as well. So I think that might have kind of added to the picture if we had done something like post-op imaging. But overall, I think that this case really illustrates the importance of utilizing a full-length array given this risk of progressive hearing loss. And we've got just a few minutes, so I'm going to go through this one pretty quick, but this is a case study just to illustrate that you don't have to have, whopping great normal thresholds in the low frequencies to derive really significant benefit from EAS. This is a 68-year-old female with, again, progressive bilateral hearing loss. We didn't know the origin. It wasn't quite as rapid as the other cases, but she qualified under traditional Medicare criteria, which just means that she didn't have all of that good low frequency hearing. So we implanted her with a Flex 28. We activated her at 1 month. We activated her EAS at 1 month. And the main reason was for sound quality. She was just really struggling with the tinniness of the sound. So with the post-op audiogram, we can see on the right-hand side at 1 month, that resulted in an acoustic cutoff of 250 Hertz. So we fit her with a silicone ear mold. I thought I was doing a good job selecting something that was kind of low profile with a canal lock, but you'll hear some of her concerns about that later on. But we fit her with an FS4 strategy with the complementary acoustic component. And her response to EAS activation was great. She loved it. She said that it was immediately less tinny and easier to hear. And that actually showed up in, I think, her speech perception scores. So this is looking at her AZ bio score in quiet, pre to post-op, 1 month and 3 month, and you can see really marked improvements in her scores. But what's interesting, we'll see on the next slide about this patient is, despite this really awesome benefit, she would arrive to her appointments without her ear mold. She just wasn't really into complying with routine ear mold use. So we use this as a counseling point, and I would put her in the sound booth and do the testing without the ear mold on. So this is a truncated map. And this is going to be, if you're looking at these scores down here, this is the EAS off condition. And then we'd plug that ear mold on and we'd do the testing in the full EAS condition. And as early as the 3 month milestone, there is a difference clinically. I don't know how significant that would be, but by 6 months, it's pretty dramatic, that difference between those two conditions. And then by 12 months, it's a pretty staggering difference. So really the bottom line here is that EAS was providing substantial benefit for her, even in a quiet scenario. So imagine what that was doing for her in background noise. So solutions, we counseled on this, that it's important for full cochlear coverage. She needs that full spectral picture to understand speech clearly. And then we went ahead and remade the ear mold to mimic exactly what she liked on her hearing aid side, this acrylic little shell. So learning experience for us on the ear mold side. But as far as her long-term outcomes, she continues to get good benefit from her EAS. This is speech scores out to 18 months, and she's doing really exceptionally well. And she's actually still using her EAS component 4 years post-op. So in summary, we're seeing good EAS benefits for patients with long arrays with varying degrees of residual hearing. And what's exciting is that hearing preservation is definitely possible, and we're seeing it in our cases in clinic, even with very long arrays like the FlexSoft. But in future considerations, I think we might start to see more utilization of things like pre-op electrode planning in conjunction with our audiogram for EAS cases or potential hearing preservation cases, and then incorporating post-op imaging so that, again, we can better match our frequencies with our acoustic and electric boundaries, just to get things, closer to sounding natural. And that's all we have today. Just want to thank you guys for our time, and we might have just a moment for some of those questions.
Thank you both so much for sharing that. I think it's so helpful for others to hear your actual clinical experience as they're thinking about management for these patients audiologically. So again, thank you for sharing not only your data that you've collected, but those case studies as well. Now, before we get into the questions in Experts Online tradition, we will take a group photo. If everybody that is on the call can turn their cameras on for a moment, raise up your coffee or your water if you've got it, and we can take that group photo. So let's see, give everybody a minute to turn their cameras on here, and we can give your best smile in 5, 4, 3, 2, 1. Smile. All right, great, thanks. Hopefully we got that. All right, a couple questions that came in. Going back to that first case study where we showed the initial decrease in residual hearing at activation that came up over time and improved. Michael asked if you had any ideas about how to explain that recovery of residual hearing in that 1500 Hertz to 4000 Hertz range at that 12-month visit. So in that mid to high frequency region, showing that improvement at 12 months. Any thoughts on that?
From that far out, I'm not quite sure. I know that early on from, activation to 1 month, a lot of that's middle ear fluid post-operatively, but I don't have, I'm not quite sure what's behind from, everything from out to 6 to 12 months, why there's this lovely recovery of hearing. I'm not sure if Britt has Any ideas?
No, I think that's what's tricky with some of these progressive unknown, like all the etiologies for our case studies are essentially unknown. And I think that's what's tricky is we don't know what's really going on in the inner ear. And why, and I think that's also when we're doing some of these acute audiograms to make recommendations, we do want to get a few data points if we've had like a sudden drop and make sure that this is really real and not something that's going to recover. So, I'm not sure how to explain that if there's like some kind of inflammatory response or sometimes we've seen that with autoimmune conditions too. Some of that like fluctuation, if you will. I wouldn't describe his as necessarily fluctuating because it really was over the course of 12 months. But yeah, I think there was something to do with whatever was contributing to the progressive nature of his hearing loss that just, resulted in recovery later on.
That makes sense. I think that's a really good note too, is that even as you're looking farther out and continuing to test residual hearing at those follow-up visits, if someone does have good residual hearing and then you see that change at 6 months post-op, check it again, and make sure that it's not just allergies or something like that
Right.
going on that caused that drop. So I think that's a great point. We had another question about how close the activation appointment is to surgery. So how long after surgery do you wait to do the CI activation typically?
About 2 to 4 weeks. We had a brief moment where we were doing it, 10 days after surgery, but there's just so much swelling still over those internals that magnets just had a hard time sticking. So we're looking 2 to 4 weeks. With wait times now, it's actually probably an average of 3 weeks now. Yeah, that's our range post-op for activation.
And I think just, again, thinking you sort of have a range of patients here with different experiences in terms of how much residual hearing they have. And it seems to me that overwhelmingly the report when you add that acoustic is an improvement in sound quality. Just to sort of confirm, that is your experience, that you don't have patients who are reporting, distortion or decreases in sound quality or really any trouble integrating that electric and acoustic. Is that true? Can you speak to that just a minute more?
Sure. I would say the only times I've had difficulty with like retention, I have a couple of patients who've had strokes, and we've implanted the side that was affected by the stroke, which meant that hand struggled with getting the ear molded and then putting on the processor. So in those situations, kind of like one of the Dylan talks about, full electric, truncated, or ES. We just created a truncated map in his situation. That way he wasn't being overstimulated with anything, was still getting most of the sound quality he liked, but not the frustration of the ear mold. So there are times where for patient ease of use, we just remove it and truncate a map, but that's not too common, I would say.
I can also add, I had a case where we ended up with a truncated map as well. She was an EAS candidate, so she had a sloping hearing loss, and her hearing aid use prior to activation was pretty poor. So we did a trial I had her wear it for 6 to 12 months. So we fit her with her Sonnet EAS, and I could not get over the occlusion effect. She was reporting a lot of that. And so I was making a lot of acoustic gains, but it's something I've thought about a lot since. And I wonder too, if another approach could have been maybe disabling like electrode 1. We didn't do any imaging, like I said. So, our protocol wasn't to do imaging unless there was a real big issue with speech perception. So she was doing well enough that we didn't need to get a scan, but I wonder if maybe there was just some interaction with her fine structure and her acoustic gain. We saw that with one of Sarah's cases, that we have to roll off fine structure. And we do that sometimes with standard mapping. But I think when you add in that acoustic low frequency, things like occlusion, you just need to be kind of conscious of. And at the time, I hadn't really explored the idea of maybe trying something like disabling a channel in the apex. But I know that I'm reading more and more that that's something that people might consider as well.
Exactly. I think as we begin to incorporate maybe more post-op imaging into our clinical protocols, if we know that there is an electrode that lands in that acoustic hearing region, we can think about even maybe turning down that MCL rather than disabling it entirely, so that in the future, if they need that, if they have a change in residual hearing, then it's easy to just turn that MCL back up. So definitely, right, as you mentioned on your summary slide, some things to consider as we move forward and continue to learn more. So, yeah. All right. I think that is all we have in terms of questions right now. I think we are just a few minutes over time here. So thank you again, everyone, for your time. And we'll have more Experts Online sessions coming in the future. So stay tuned, stay on the lookout for more information about additional topics that will be coming in the future. And thank you so much, Dr. Funatake and Dr. Wilson, for sharing your experiences today.
Yeah, thanks for having us.
Thank you. This was
Everyone have a good
great.
day.
Thanks, guys.